Hey everybody, welcome to In-Flight Delivery, where we're going to look at a case study of a 32-week neonate. Objectives today, we're going to look at specifically anatomical differences seen in the pediatric and neonatal population. We're going to identify resuscitation endpoints, look at fluid management, and really all the treatment considerations for this population that we don't get a lot of experience in if you're a standard provider that is working ground, maybe in the ED as a nurse, ICU as a nurse. Unless you're focusing on that specific age group, you don't have usually the confidence to treat these patients day after day. All right, let's look at our case. You are just finishing checking your aircraft off. It's a great, nice July day. It is very hot and humid outside. And you and your partner are talking about what you're going to do the rest of the day, maybe planning some lunch, barbecuing, and you get toned for an interfacility transfer out of your local hospital. So this hospital has about 15 beds in their OB unit. They do not have pediatric or NICU capabilities, and your transfer is going to be about a 50 minute flight where this patient is going to have those capabilities available. You're currently flying an EC-130 aircraft. Your patient, you were told, is 23 years old, has had good prenatal care, currently Gravida 1, Para 0. No medical history, has been very healthy her entire life, and she has prenatal care from the time she identified she was pregnant until this point, and she currently is 32 weeks gestation. One of the things I want to talk about really quickly is really the mode of transport, whether you're in an ambulance, whether you're in a helicopter. If you're moving your patient from the ambulance or helicopter into the hospital, we have to really make good decisions and have the ability to understand our surroundings. As you can see in this picture, if you are an EMT, a paramedic, or maybe you're a nurse and you work in the ground transport side, you have access to this patient all the way around. You have access to the head and the feet, and you have plenty of room. Obviously, you have lots of room in a hospital. What about moving your patient up from the ED to an OB floor? Do you take the OB kit with you? There's been many cases out there where a mom has delivered in the elevator, so just always be cautious. Don't get complacent. Make sure you're prepared. And I will talk about some lessons in this case for me to reflect on. As I said, we're flying in an EC-130 aircraft, and this is a great aircraft for a single-engine aircraft, lots of power, probably one of my favorite aircrafts I've ever flown in. It gives you a great ability to look out. You can definitely see everything, but it also gives you a really good area to work on your patient. And you can see here that your access to the patient is really great. So this sled articulates in, it goes sideways, it goes, diagonally, but we would slide this in and the head obviously is facing where you're seated. And so it really sits in between that right seat and that open spot where you see the ventilator. So the person sitting in this seat right here can easily access the patient from the patient's right side, and you can go all the way down to the feet without difficulty. The key, though, is understanding, your guidelines, understanding your training, understanding the age of the baby. Remember, this baby is 32 weeks gestation. Do you have the equipment? And, this lecture is about lessons. Do you check your aircraft off? Do you check your ambulance off? Do you specifically look at those areas of your equipment? And I would reflect back and say, that's not always a priority. And I don't mean that in a bad way, but let's just be honest. Sometimes we rush things. Sometimes we get on shift and maybe you get toned for a call immediately. And by the time you get done, you have not even checked off your equipment. And so it's super easy to become complacent. I mean, let's just be honest. It really is. And do you have everything that you need for these patients? I'd also say, do you have the training? Most advanced providers have PALS, or it's recommended to have PALS. Some states require PALS, some states don't. Some states require PALS if you're going to fly as a flight paramedic. Some don't. Not all EDs require PALS for nurses. Some do. So again, do you have that? Do you take it a step further, and do you have NRP to fly as a critical care provider in the aeromedical industry? If it's a CAMES accredited program, it is required to have NRP. You have to have NRP. Have you taken a course called STABLE? These are great additional courses that really give you a wide perspective and the ability to treat your patient on a higher level. And so, do you understand your algorithms? Do you understand those key areas? And what I would say, if you're an EMT listening to this, if you're watching this on YouTube, if you're watching this on the Emerge LMS, an EMT is essential, right? Our advanced providers that are listening, your skill level is really foundationally based on your BLS maneuvers. How well do you assess your patient? How well do you manage the patient from a basic standpoint? We can't stress how important that is. As we walk into a room on any OB transfer, we have to obviously do a good assessment. And I think it's super easy, again, to get very routine in these transfers. This hospital that we sat next to, we did a lot of these transfers. And so this was not an uncommon type of flight. And I've given this example, this case example, many, many times. And it's funny how you hear different thought processes. There are some out there that would say, you know, at 32 weeks gestation, I don't know if I would take this flight. Maybe do we go by ambulance? The problem is it's not always that simple. And, you know, really from an aeromedical standpoint, there are a lot of factors that play into that. If you're a ground agency that's in, and that is the county that you are in, you know, even taking it from a private ambulance like AMR or Rural Metro that's got an assigned ambulance service area, and you relate that to a county-run EMS agency that is run by that county. They don't have any competition. They're not going to be, you know, ever in a position where the threat of having somebody come in is a big thing. You know, you probably can turf those off, or you can say, you know what, I don't feel comfortable taking that. Really, in the aeromedical side, that isn't as common, and a lot of times you have competition. And so, to say it as nicely as I can, a lot of times, you know, that's never going to cross your mind. You're going to take this patient in most cases. As we walk in, though, we want to obviously introduce ourselves. We want to make sure that we understand everything that's happened. So, you know, get a report. But one of the first things I do once I introduce myself to my patient, my partner, is I want to look at really the past medical history, what's happened to this point, and then I'm going right into a fundal exam. And so why is this important? I think this is very often missed. It may not have been taught to you, but man, I cannot emphasize how important it is. So the first thing I do is I always introduce myself. I'm going to explain what I'm going to do. And obviously, if the patient has been in the hospital for, you know, a few hours, they've probably had this done to them, and they've had this done to them if they've had any prenatal care. So it should not be a big deal. First thing I'm going to do is I'm going to let the patient know I'm going to touch them. I am going to identify the top of the fundus, as you can see in picture A here. And I like to couple this with A and C. So my left hand, if I'm standing at the patient's left side, I prefer to do that. I'm going to place my right hand on the top of the fundus. Left hand is going to go down, and it's going to basically palpate until I get above the pubic bone. I'm just going to come down the fundus until I palpate and feel the top of the pubic bone, and that's where I'm going to be able to identify the head, as you can see in picture C. And then I'm going to gently palpate both sides, as you can see in picture B. If you note in this picture, the provider's right hand is pushing in a little bit further than the left hand. And that's telling the provider that that's the stomach area of the baby. The left hand is more rigid, it's more hard, it doesn't give. That's the back of the baby. And so that gives us a few good ways to assess our patient further. Number one, where my left hand is, I know that's the back of the baby, and I'm going to be able to identify fetal heart tones in that location. But why do we do this? Well, we're doing this because we want to be able to identify fetal lie. We want to be able to identify not only fetal lie, but we want to make sure we don't have a breech presentation. We also want to make sure it hasn't been missed and there's not twins or triplets. And so, for example, if I highlight this area here, right occipital anterior, so this baby is sitting very similarly to what we saw in the previous slide, but notice the back and the occipital region of the baby is more anteriorly positioned. And so if I palpate the fundus with my right hand, I palpate right above the pubic bone, identify the head, and you should be able to feel that that head is turned and that occipital part of the head is more anterior. It's not laterally pointed. Palpate. I've got a rigid feeling on the left side. That's telling me that's the back of the baby. And so I would document this in my charting. Fetal lie, right occipital anterior. You can abbreviate that with ROA. And you can look at all of these presentations. This is very, very simple to do. It's very easy. And once you do it a few times, you're going to be very comfortable with this. The next thing we want to talk about really is you should get information from the hospital, from the OB nurse, maybe the physicians in there. Is mom dilated? What's the effacement? And really, what is the station? And I want to point out station here. Station really is a reference of where that fetal head is in relation to the pubic bone. And it's measured in centimeters, and it's from -3 to +3. And so you can see here this gauge, right? Baby in this example is right there at 0. But as the baby starts moving down, again, we're -3, and you can see we're now -2, -1, and we're at 0 station. And now we're +1, +2, +3. This is not something, obviously, you're going to do. This is information you're going to have relayed to you along with cervical dilation and effacement. And I would say always, always, always ask, when was the last time the patient was assessed? If they say the patient was last checked an hour and a half ago, it is really important, even if it delays your transport, to have them checked before you leave, right? This case, I will highlight why that is so important. Next thing I'm going to do is I'm going to look at the tocal monitor. Do you have a tocal monitor that you're going to have with you? Well, most programs don't. I can tell you I've never worked on an ambulance that has that capability. And honestly, flying for almost 20 years, I've never had that capability on a helicopter. That doesn't mean that that doesn't exist, and I know programs out there that do. But one of the things I want to identify is, what is my fetal heart rate? When you can see here, our fetal heart rate fluctuates between 150 and 155, and that's excellent. And we also want to identify, what is the response? What's the heart rate doing in response to that contraction? And what we want to see is good variability. We want to see those accelerations, as you can see here. The top part of this tocal strip is the heart rate. The bottom part is the contraction. And so you want to see that variable up and down of that heart rate as it relates to those contractions. Now, in contrast, we're not going to spend a lot of time on tocal strips. What we don't want is early decels. Notice that you see a heart rate that drops at the point of the contraction. And so that's telling you that this baby is in distress, and that is not something we want to see. And so again, we want to really look at that tocal strip and make sure that we understand really the big picture, because this might be the only time that you have that ability to identify these changes. Continuing with our case, the patient is currently comfortable laying left lateral recumbent. She states she is in no distress. You're told that she's having contractions about every 8 minutes. They're lasting for 30 to 45 seconds. You're told that she is 2 centimeters dilated. She's about 50% effaced. And when you are told medications, she has had a dose of terbinafine, she has had betamethasone, and she has had a bolus of max sulfate of 4 grams, and she's on a 2 gram per hour infusion at this point. Another assessment area that we have to always ask for is, was this patient treated? Is there an antibiotic running for group B strep? Now, for this patient is 32 weeks gestation, and so 100% this patient should have some type of antibiotic running. Usually it's penicillin or a first-generation cephalosporin that is targeting group B strep. And the reason why 100% of the time, if they're less than 35 weeks gestation, or they have not had an OB appointment at that 35-week range, 36-week range, you need to ask. They are never treated for group B strep until that point. So any mom less than or equal to 35 weeks, again, if they're right at 35 weeks, I would always ask, they must be treated for group B strep because they have not been tested. Even if you're told that in the first pregnancy or the second pregnancy, if they've had multiple pregnancies, they were group B strep negative, that does not mean they're not positive now. And this is the number one cause of neonatal sepsis, right? From a vaginal birth, we would also, look at this from the standpoint of, does the mom have any UTI? Does the mom have herpes simplex virus? Anything like that can be transferred to the baby and should be a consideration. The big thing I focus on, though, is that group B strep. All right, case update. We are loaded in the helicopter. Husband does come with us, and we are en route to the University of Kentucky. We're about 10 minutes into the flight. We're at cruise altitude. Again, it's a hot July day. And we notice the patient becomes a little bit restless. She is laying left lateral recumbent. She is semi-Fowler, but she's starting to rotate and want to lay on her back. And, you try to talk to her and you identify through assessment and conversation with her that her contractions now are about 2 minutes apart. You look at your watch and you're 40 minutes away at this point. And so just based on good measure, you and your partner talk and talk to the pilot. We identify kind of where we're at, and we're about 5 minutes out from a small critical access hospital. And so just to make sure that we're good, pilot starts heading that direction. As we're heading that direction, things go downhill very rapidly. You're trying to get mom to breathe. At this point, my partner is trying to get her to breathe and really focus on him. And I decided, it's probably best that I go down to the foot of the bed at this point, make sure she's not crowning, which I do. There is quite a bit of bloody show, but I do not see any crowning at this point. And then all of a sudden, she pushes once and I have a baby in my hand. So this is where it gets real. And we are 3 minutes out from landing. We have a neonate precipitous delivery on a mom that was gravida 1 para 0, right? It goes against everything that we are taught. And she was 2 centimeters dilated, contracting every 8 minutes. Again, everything that we're taught, right? Things changed very rapidly from the point of taking her out of the hospital until now, 10 minutes later. Let's talk about the stages of labor real quick. Stage 1 is really the onset of contraction. So when she started contracting this morning, that was stage 1. This is when you start seeing the cervix thin out, which is called effacement, and the cervix dilating and widening out. And that is really a big part of that whole delivery process, or the labor process, I should say, is stage 1. And this is going to be dilation up until that birth phase. So stage 1 is really the contractions, again, effacement, dilation. And then when you get into stage 2, you have that point all the way through to birth. And then stage 3 is going to be that placental delivery. So now that we have a baby born, we have to quickly assess the situation. Want to make sure that that baby is at the level or lower than the canal. Remember that based on NRP guidelines, we only suction now, right? We're not using a bulb suction anymore. We're only suctioning if we see severe meconium present, and we would, suction just based on that. But we're going to immediately dry and stimulate. Can't emphasize how important that is. And the thing that makes this difficult is, depending on the environment you're in, do you have the towels? Do you have the means to do that in an easy way? We're going to assess the heart rate. Heart rate is key. Have to have heart rate in any neonate, any infant. That's what generates cardiac output. And we're going to immediately at the 1 minute mark assess our APGAR score. When we look at APGAR, and we look at APGAR really in 3 phases. At the 1 minute mark, as I said, at the 5 minute mark and 10 minute mark, we're going to look at appearance. Is the baby pink? Is the baby cyanotic? Is the baby blue, right? Are we at a heart rate that's appropriate? Do we even have a heart rate? Is the heart rate less than 100, which is important based on NRP guidelines? Or is our heart rate greater than 100? Does the baby have grimace? Is there no response at all? Is there some mild facial movements, or does the baby pull away, right? Most babies are going to pull away. They're going to have some ability to, withdraw from you. What's the activity currently? Is there a good muscle tone, or is the baby flaccid? And what is the respiratory rate currently? Is it regular? Is it absent? Is it irregular? And we're going to give an assessment at that 1 minute mark, and then we're going to try to see improvement again at the 5 minute mark and 10 minute mark. Obviously, we have a baby. Do we cut the cord? How quickly do we cut the cord? This is something that's fairly new. I think many of us were taught originally, you clamp and cut the cord. Make sure you give yourself plenty of room. They say 8 to 10 inches, but make sure you clamp and cut. But now they're saying that, delay that cord clamping as long as possible. And why is that? Well, really from 2 levels, right? If you have a full-term infant, that increased blood volume that they get from leaving the cord in place and not clamping it really does increase blood volume in iron stores, and that has been shown to be beneficial. But from the neonate standpoint, any premature babies, it reduces the need for blood transfusions. It has been shown to reduce the risk for necrotizing enterocolitis. And one of the things you see in these little neonates when they get stressed, specifically, there's other reasons, but they often will have intraventricular hemorrhages in their brain. And so anything we can do to reduce those risk factors is essential. So what I would say is do whatever you can to delay that cord clamping as long as possible. Obviously, you got to treat your baby. You got to treat your patient. You got to be cognizant of those things. Make sure you don't put the baby above the canal. Make sure the baby's always lower, and they will have good results. Where do we focus our resuscitation, right? Whether you're taking NRP or you go back to PALS, whether you're an EMT, we can use these different tools to really guide our resuscitation. If the baby is newborn, we would use their weeks in gestation based on when they were born as their minimum MAP. And so that is the first thing. Any newborn baby, if they're full term, 40 weeks, their minimum MAP is 40. meaning that we would treat them if their MAP was less than 40. And we would treat them based on volume. Maybe it's a respiratory type issue. Maybe it's a heart rate issue, right? But we're going to make sure that we drive that MAP greater than whatever their gestational age is in weeks. And we document that as post-conceptual age. So for this specific case study, the post-conceptual age is 32 weeks post-conceptual age. His minimum MAP needs to be 32 or greater. Once they get up to 44 weeks post-conceptual age, so for this guy being 32 weeks, we have a ways to go. We could then convert that and use a blood pressure target. And notice 70 plus 2 times the age is going to be a minimum systolic. And so if we're less than that, we would treat it. 90 plus 2 times the age is going to be a normal systolic. And that works really, really well. ET tube size. If you escalate to the point where you have tried to manage this patient with a BVM, maybe you're using blow-by, maybe you're using an on rebreather or nasal cannula, and you say, you know what, we have to escalate to intubation, a great easy way to do that is simply take the weeks in gestation, as I have here, and move the decimal point back one spot, and that's your ET tube size. So for this little guy being 32 weeks gestation, I'm going to move my decimal point back to 3.2. Obviously, we don't have a 3.2, but I would use a 3.0. I might even grab a 2.5 and a 3.5 just to have it right there, ready to go just in case. Obviously, you can use the kilo method as you see here, but I found that to be a very, very easy way, just using the weeks in gestation and moving it back. And so a 40-week gestation baby would be a 4.0 ET tube. Great way to identify ET tube. There's the old age plus 16 divided by 4, but remember that only works when the patient is 1 year old or greater. And then if you want to quickly identify, hey, what's my Foley catheter? What's my NG or OG tube? What's my suction size, French size? Just double the ET tube size. That works not only from the neonate population all the way to the adult population. And you can quadruple that, multiply it by 4 for a chest tube. So for this little guy, if I'm using a 3.0 ET tube, I'm using a 12 French chest tube. And so that works really well. Again, that works all the way up through the adult population. As I said earlier, we got to have the alphabet soup. We got to be able to constantly give ourselves the best opportunity to learn and be able to handle these patients. And so highly recommend, if you've never taken stable, take stable. And as I said, NRP is a must if you're working in the critical care ground environment. And stable uses a acronym of stable, and really you're assessing sugar, you're looking at temperature, identifying airway, treating airway, blood pressure, again, MAP, looking at your labs, and then providing that emotional support for the family and anybody within their group. And then NRP, it's focused on that heart rate, right? Got to get that heart rate above 100. We resuscitate with positive pressure ventilation if that's not the case. Everything is done in 30-second increments. If you don't have a response after 30 seconds, then you escalate to the next step. I don't think it's ever wrong. If you're in doubt, your heart rate's less than 100, you're not seeing any response, start chest compressions. We're going to talk about the lowest SpO2 based on minutes after birth. And I can't stress it, limit that FiO2. And so NRP really focuses on this. This is not something that is commonly taught in just normal school. If you're a paramedic, you may not have ever learned this, but really, when we look at FiO2 administration in the newborn, high FiO2s cause harm. We've got to remember that when the baby is in the womb and they're in that gestational growth phase, their SpO2, they're number one, breathing in a fluid environment. So their lungs are filled with fluid, but their SpO2, if you were to measure that, would probably be in the 50s. And so now you're bringing them out into a new environment. And you can't expect their SpO2 to respond that quickly. It's not going to skyrocket up to a normal level of 93, 94% like we would want to see. And so really the focus should be, what is that heart rate? If that heart rate is appropriate, then everything is good, right? But if the heart rate is not appropriate, give positive pressure ventilation with room air FiO2. We're not giving any excess FiO2. And you're assessing that SpO2 based on every minute. Well, how do we do that? Well, we use a preductal measurement, meaning that the SpO2 probe needs to be on the right arm, right hand. And that's going to give you that preductal measurement. What I would caution you is, if you're working as a flight crew and you're working with a ground crew that maybe has never had NRP, and you're seeing consistently, 65%, 70%, right, based on 2 or 3 minutes after birth, make sure you explain that to the ground crew. They may not have had that education. It's going to be very confusing. Think about if you saw a normal patient with SpO2s of 65, 70%. And so they're going to see you not treat that with FiO2. That's going to be very confusing. That could cause some problems. So always explain, go into education mode and explain why you're doing what you're doing. Remember, there are anatomical differences. There are differences, even though we want to, in our mind, say that adults and pediatrics are the same. They are different. We have to remember that their bones are very soft, so they're flexible. Their lungs are baby lungs. And so, really their chest cavity, because of how flexible it is, they have good expansion ability, but their lung compliance is actually very poor because of minimal or a lack of surfactant, again, based on the age. Surfactant really does not become dominant, and your type 2 pneumocytes do not produce surfactant to the level that they need until 37 weeks gestation. So for this guy, 32 weeks, this baby does not have surfactant production, and that really causes a potential problem. So compliance is going to be very poor. Their liver, their spleen are much larger in comparison. So very easy in a trauma situation, maybe an abuse situation, to damage these organs. We do have great ways to assess our patient. So don't forget to look at those anterior fontanelles. That's a way to assess that really until that baby is at least 18 months old. Do we have a sunken fontanelle? Maybe the patient needs some volume. Is it a bulging fontanelle? That's an indication of an increased ICP issue. Your posterior fontanelle will be a good gauge in that newborn, but after about 2 months, it's not going to be available. It does close. And I can't stress, remember, these kids do not have any way of regulating their temperature. Their hypothalamus is immature or not working to the point of even being able to regulate their body. They have no insulating brown fat. And so they're going to, based on the high amount of body surface area, they're going to lose heat very, very rapidly. So here's our case update, guys. We do an APGAR. Again, we're in flight 3 minutes out. I identified I have a weak brachial pulse. It does match, from what I could tell, to be honest with you, it does match the umbilical cord pulse, but I was really unsure. No respiratory effort whatsoever. Neonate is blue at this point, no grimace, very, very, we'll say, floppy, no tone. APGAR at that point at 1 minute was a 1. Now, let's go back to how this happened. And let's just be honest. In this situation, if you were flying a patient like that, would you have the pediatric kit in the front of the aircraft? Absolutely, and we did. But was it open? Was everything readily right there where we can grab it? Well, no. Who does that, right? Was there an OB kit in the front of the aircraft? Absolutely. But was it open and ready to go? Well, no. And that's the thing is, it's one thing to know, hey, you know what, we're probably going to deliver a baby, but this happened so rapidly. Within 2 minutes, this baby, she started contracting to the point of delivery. And so things happened very, very quickly where nothing was out and ready to go. So at this point, based on that, the only thing I could do, again, I'm at the feet of the gurney. My partner is trying to get equipment out for me, and I just decided to start chest compressions, right? I don't have a BVM available. I don't have anything like that. I think what we did do is we pulled the non-rebreather off of the mom really quickly, and I set it next to the baby. I felt like that was the quickest, easiest thing to do, and started chest compressions. Once chest compressions were started, we did transition to a BVM, and we did started noticing a little bit of change in the baby. We land at this small hospital. We, at that point, aircraft is shut down. Partner jumps out. I clamp. We cut the cord together and grab the O2 bottle. We actually landed on our another aircraft's pad, and that flight crew came out and stayed with the mom, and we ended up hoofing it on foot about 150 yards up a sidewalk to the ER. Now, mind you, we were not able to even call in. This happened so fast, we were not able to call in to the hospital that we were coming, so you could imagine their surprise. Again, this is a critical access hospital. Basically, the pilot called into the company's aircom and just said we were diverting and landing at this pad. Again, they didn't have a lot of information either. So let's go back to heat loss again. We got to prevent for all heat loss. And again, I've said this many times in this case. This was a hot July day, very humid. And I think I reflect back now, even though we were really good about drying and stimulating, putting a hat on his head, trying to limit that heat loss, the baby got a little cold. Baby, I think, got down to about 96 degrees Fahrenheit. And so even though trying to do everything we could do, it still was very, very difficult to keep the baby from getting cold. And so imagine that being in the fall or in the winter months. It's going to be even worse. Try to put something on the head, the feet. Obviously, most OB kits have hats nowadays. And just remember that high body surface area is a great way for them to dissipate. They don't have the ability, they don't have that insulating fat. As we roll into the ER, we really didn't stop and say hello. Obviously, they were very surprised. We turned left, went right into an exam room, and continued resuscitation. Nursing staff was great. They came in and they gave us all the assistance we asked for. We did intubate. I was able to intubate first pass success, but during the securing process, I did dislodge the ET tube, had to re-intubate. We did confirm ET tube placement, used a 3.0 cupped tube with end-tidal CO2, and we secured that and then placed an OG tube. From this point, we, again, continue to have help from the nursing staff, and we reassessed APGAR score. We were at a 5 at this point. Airway management was taken care of. We were secured. We had a heart rate greater than 100, so that was great. And now we were moving on to that IV access. And here's what I would say. If you have done umbilical vein catheterization and you're good at or feel comfortable with UVC attempts, then knock it out. I will say that I've had 3 attempts, 3 different situations on UVCs, and I've never been successful. Talking to NICU teams, teaching the CMPT, and really conversing about this topic, that is very common. It doesn't mean that you can't access and go that route. But what I would say is, unless the baby is in pretty profound shock, it's not as easy as it seems. We found that we did not have catheters small enough for this baby's size. And so even having our pediatric bag set up to go all the way down to, babies that would take a 2.5 ET tube, we still did not have a catheter small enough. But once we failed and then attempted an IV, we used a 24 gauge. Partner got this first attempt. And we've been successful in these other examples the same way. So what I would say is trust your skill level. You've done thousands of IVs over your career. You should go that route if you can. Use an AC, even if you go blind and you can't see a vein, maybe go a scalp vein. Do something like that. I would definitely advocate to go that route first rather than try to do a UBC first. Don't ever forget that volume is key. We've addressed the airway. Any newborn, any baby up through 30 days after birth, we would always treat with 10 cc's per kilo. Don't stop after your 3 10 cc per kilo boluses. If the baby is that dry, continue until you see a response. Again, we're looking for those endpoints. We were going to use a map based on gestational age, post-conceptual age, so 32 weeks, 32 millimeters of mercury on our map or greater is our goal. And so that is and should be your focus. We under-resuscitate kids in the context of volume replacement. And we often stop after 3 boluses, and many times the baby needs much more than that. We have to also remember that the circulating blood volume of an infant, a neonate, is 75 to 80 mils per kilo. If you translated that to a 7 kilo baby, which is much bigger than this baby, that's only about 500 mils of volume, of total circulating blood volume, 500 mils. So think about a 500 mil bottle of water, but it only takes a small amount in context, 25% loss, to cause harm and to see decompensation. So always remember, it doesn't take a lot in comparison to the total circulating blood volume. Once we've given the boluses and we are assured that the baby is where they need to be, we then need to start a maintenance infusion. And we always use the 4-2-1 maintenance fluid formula to do that. It's best to always go 5% dextrose or D5 quarter or D5 half normal saline. But it's very, very simple. You're going to basically take the baby and you're going to divide up the weight in kilos into 3 sections. So if the baby is from 0 to 10 kilos, then it's very simple. This baby was 2.5 kilos, right around 5.5 pounds, and 2.5 times 4 is 10 mils per hour. Because we don't have any weight between 10 and 20, we don't need to do step 2 or step 3. So an example is if this baby was 16 kilos, we would do the first 10 kilos and put that in that first box, and that would be 10 mils. And that would be 40 mils. We would take the next section between 10 and 20, and that would be 6 left over, right? 16 kilos, 6 left over times 2 would be another 12 mils per kilo. So that's how you would do that. And if the baby was, or pediatric patient was over 20, you take whatever is over 20. So this formula is not just for neonates. This is for any pediatric patient. And I would say you would use your local guidelines. Some say up to 8, some say up to puberty. Again, use your best judgment. Next thing we want to do is we want to make sure our sugar is adequate. Again, we're going through this in this lecture, but we're doing this very rapidly. This should be part of, once that IV stick was done, check that sugar. And we did, and sugar was 36 grams per deciliter. So we need to treat this. Remember, kids are going to spill sugar. They have no ability to generate heat, and so shivering is one of those things. But based on that, shivering is always limited to our glycogen stores, and their glycogen stores are very depleted, especially just now being delivered. Any pediatric patient is going to have a stress response to their environment and the stimuli around them. And so a lot of times you're going to see kids spike their sugar. Their sugar might be 130, 150, 180. Always understand that it's going to drop. So always check repeated sugars through your care. For him, we knew that our protocol was less than 40 is treatable. We did treat with D10. Again, usually 1 mil per kilo is a very standard dose. And then again, keep repeating and checking that sugar. What if you transition to mechanical ventilation? Do you have the equipment available to do that? And remember, all ventilators out there except for the Hamilton is FDA approved to 5 kilos. The Hamilton is only ventilator out there as a standard transport ventilator that is approved down to 3 kilos. So understand your equipment. It doesn't mean you could not use another ventilator, but I would always turf that to the medical director and let them approve that, because we have to use pressure control ventilation. All the ventilators have that capability, but we have to know there are differences in that population and how we deliver that breath, your eye time, what your standard pressures are going to need to be, what is your standard rate, etc. So just make sure that you're well versed in that area. As we go back to our case, we do move the patient out of the ED. They have a small OB unit that was like 5 beds. APGAR score at this point is 10. We have seen a big improvement. The baby is pink. Heart rate is right around 140. Good vigor, good tone. And as we move the baby into the OB unit, we're there for maybe 3 or 4 minutes. We notice him moving his arms, and he does pull at that ET tube, and he extubates himself. Obviously, that was not ideal. His SpO2 preductal was at that point about 92%. And, we discussed, do we want to re-intubate? We watched the baby. At this point, an OB doc had come in. Obviously wasn't a pediatric physician, but based on our conversations and really what we assessed, we felt like he was doing well. We transitioned to a nasal cannula, and he maintained really well at, I think, right around 30% FiO2. In summary, guys, I think preparation is key. We have to understand what we don't know. We have to prepare, know your equipment. I think looking back at this call, I was a little bit surprised in some of the pieces of equipment we grabbed, even going to our smallest 2.5 kilo bag, that we didn't have things that we needed. I think in hindsight, not having the OB kit right there out and ready, I think it definitely caught us by surprise. I think we did great in the circumstance, but I think that precipitous delivery really did change the dynamic. And even having the pediatric bag there in the front of the aircraft, it still caused us to have a delay in getting certain equipment. Any premature delivery is going to bring with it elements that you're not ready for. And so practicing these things are key. And that's where taking courses like NRP, stable, understanding the differences in those 3, and standard PALS approach is a little bit different than NRP. But I would say that really when you get into a lot of the PALS stuff in these newborn babies, a lot of it is translatable. Assessment should be APGAR, should be looking at heart rate. You want to see those improvements consistently. Remember, gestational age, post-conceptual age, that's your minimum MAP. Minimize oxygen delivery. I can't stress that enough. That is so important. Lowest FiO2 based on minutes alive. FiO2 causes 2 problems. Number 1, it actually causes a reverse response in our kids in relation to what an adult would do, and it's going to actually change their ventilatory response when you drive up the FiO2. It also causes retinal damage. Again, that happens at a greater risk the younger or more premature the baby is, but it also causes premature closure of the patent ductus arteriosus. We want to let that close naturally. We don't want to aid in closure. So no hyperoxygenation. Use room air. If anything, go to 30%, but be very, very cautious. And as I said, prepare for heat loss. Make sure that you understand, even if it's really hot outside, the baby is going to get cold. So constantly assess that part of your care. This was actually the picture after he extubated himself. Took this. This is prior to us putting the nasal cannula on. Obviously, you can see he's very red. He's very pink. His heart rate was great at that point. We did call a NICU team. They did fly down and get the baby. And so he did really well. Stayed in contact for maybe that first year. He did really good. So hopefully this case highlighted really factors that drive our decision-making. It doesn't matter how the patient presents initially. They could have very minimal dilation. They might not appear to be in distress. They might be contracting every 10 minutes. You never, ever know. Even though she was gravida 1 para 0, she did precipitously deliver. We left a lot of stuff out in this case. I could have went into great depth on medications and stuff like that. I wanted this to really be a highlighted focus on the resuscitation of this case. And if you have any questions, again, always feel free to contact me, eric.bauer@flightbridgeed.com, and I will talk to you soon.